Thanks for inviting me back. It's always lovely to be here. It was a really good workshop last time and we had a lot of fun. I think we all learned something, which was really good. And particularly like to thank George for bringing the weather this time as well. So it's been fantastic. So especially coming from the harsh Australian winter that I've just come from, where it drops down to like 8 degrees at the moment. So there has been a slight program change, not for Anton and I at least anyway, because this is the program we thought we were doing. And I thought really it's probably better to start with an overview of respiratory physiology. So this isn't just pertinent to high frequency because the lung is the same, whether it's put on a jet ventilator, an oscillator, or a conventional ventilator or CPAP, it's still undergoing the same mechanical and volumetric principles. So I thought I'd just give a brief overview of the core concepts that we need to consider when we're ventilating a baby, and then we'll build from that with a series of talks and workshops thereafter. Hopefully my talks on high frequency will be reasonably short so we can engage in some discussion, because Anton in particular has probably more experience than anyone else in the world at using high frequency ventilation in atelectatic lung diseases, especially in the early acute phases. So it would be good to have more of a panel discussion at the end, and rather than it just being lecture based, because there's often a lot of questions around, in particular, the use of early high frequency and lung recruitment and the open lung, which is what we'll both be advocating and have some experience with. So I don't know, is there... there we go. It's always the button that's the last one, right? So, there we go. And for the people in the front, that's perfect, because you can sleep and no one will see you. Sorry? Do you want them to slouch? Okay. They look very good in their posture, so maybe they'll sit at the back next time. It's early in the day, so this is meant to be interactive, but it won't be that interactive yet. I won't be that mean on you. So before we talk about the physiology, I think it's important just to go right back to basic principles, and this is all going to be really basic, and ask ourselves, what are we actually trying to achieve when we put a patient on a mechanical positive pressure ventilator? And we are trying to do only a couple of things. One of them is not using the mouse button properly. Firstly, we're essentially just oxygenating the baby, correct? We've got a problem of oxygenation, we're trying to fix it. And how can we do that on a ventilator? We can use FiO2, which is the simplest, not always the best way to achieve an improvement in oxygenation. And we can consider the concept of recruitment and whether recruitment is adequate, or possibly should we not be doing recruitment. And how do we achieve recruitment or influence lung volume? We do so with PIP, PEEP and the I time on the ventilator. The next thing we need to consider is ventilation, which is essentially CO2 clearance, isn't it? And CO2 clearance is all about minute volume. And minute volume is the rate times the difference between the dead space volume and the tidal volume or the alveolar volume, because it's about alveolar volume. And tidal volume, as all of you know, is influenced by a delta P, which is the difference between the pressure which is inflating the lung and the pressure which is being applied to the lung during the lung's expiratory phase. And at least on conventional ventilators and on most of the high-frequency ventilators to the major extent, expiration is a passive process for the ventilator. It's active from the patient in terms of recoil. We can also influence tidal volume by utilising flow and considering the resistance of our circuit, and the inspiratory time we apply on the ventilator, and finally the volume state of the lung, which is a concept that I'll talk about a bit more. And I think it's important to consider lung volume not in terms of absolute terms, but in terms of the state it creates in the lung, whether the lung is properly recruited, over-distended or atelectatic. And that is essentially a product of PEEP and the lung compliance. But as we know, we're generally ventilating babies in the NICU because they have a primary respiratory disease, and positive pressure ventilation is not natural and it can cause lung injury, and if you already have a diseased lung, you're at a state where the lung is in the process of injuring. So we need to not just consider the concepts of oxygenation and minute ventilation, but we need to consider the badness that we can be doing with a ventilator. And we need to be applying our strategy in a way that's lung protected, and we'll spend a fair bit of time talking about that. The difficulty with lung injury, as we all know, is that it is a series of conflicting events. It is not just one way of injuring the lung, there's a multitude of ways of injuring the lung. So on one side we have a series of hazards, volume trauma and barotrauma, and we can achieve that sort of state with a ventilator very easily. At the other end we have an opposing set of states that can be injurious to the lung. Atelectasis, the shear force injury, and then the cascade of oxidative and biotrauma and other things that occur if you initiate one of these two pathways. And it's incumbent on us to find a way between these two injurious states. So what are the considerations that we need to think about when we put a baby on the ventilator? Mechanically ventilating a patient takes away some of that patient's own ability to maintain certain parameters in the lung. In particular, lung volume, tidal volume, and minute ventilation. We influence the patient's own ability to do these things. We also impose extra work of breathing on the circuit on the patient by virtue of having a circuit in the ventricular tube. And in many cases, this isn't a major event, especially in preterm babies, although we need to be aware of it, especially during weaning and other things. But in some patients, particularly our older, bigger ones, that work of breathing can itself be significant clinically, and we may need to take away the baby's inability to manage that by using sedation and other parameters. And we always need to remember that a mechanical ventilator is a positive pressure device and the human lung is a negative pressure system. So it's counteractive to what the lung actually is meant to be doing. So here are my 5 fundamental questions to ask when I put a baby on a ventilator. Firstly, what's the right modality for the pathophysiology that I'm treating, not for the thing that I think is the best mode right now. So this should be patient-initiated, not clinician-initiated. Well, there are some caveats on that because in some units we're better at certain modes of ventilation than others, but you shouldn't be treating, I don't think, we should be ventilating on a Cochrane review per se, we should be ventilating on other parameters. What does the patient need? What is the physiology I'm treating? What is the PEEP that's appropriate for the lung disease and the lung volume I think the patient is going to need? What is the inspiratory time that's appropriate for the time constant of the lung and the baby's own respiratory pattern? And if you're from Calgary, you've heard all this before, you can have a little sleep, right? So we were just talking about this 2 days ago. Fourthly, what PIP is needed to produce an appropriate tidal volume? And here I use 4 to 6 ml per kilo, and we'll probably talk a bit about this afternoon. This is not the absolute mantra of what you must always use, but it's a way to start. And what is the rate that is needed to produce adequate minute ventilation and therefore CO2 clearance? So to look at these questions, first we need to say what are the different aspects of the ventilator and what do they do to the lung? So what does pressure do? And to understand what pressure is, and remember these are positive pressure ventilators, so one's going to assume just by virtue of the name that pressure is pretty important. What does pressure do? Pressure interacts with the mechanical properties of the lung. So we need to understand how the mechanics of the lung interact with the ventilator there. And the mechanics of the lung talk about the way the lung moves. And that's what we're trying to do, isn't it? We're trying to induce a volume change. That is a movement within the thorax, a change in volume causing a movement and then taking that volume away in expiration. So with a positive pressure ventilation, we apply pressure difference to the lung. We do so by using a flow of gas. We do this over a period of time, and we hope that that together will initiate a volume change. And this is all you need to know to understand how to set your pressure on a ventilator. So you just need to understand this equation, and of course I would expect that, on your ward rounds, this is the equation you're discussing on every ward round of every patient, and this is of course Newton's law of motion. And what this is telling us essentially is we want to initiate a force. If we want to initiate a change, we need to apply enough force to something to move it. So now we need to understand what forces will stop the lung moving, because we have to apply pressure on a ventilator that will be higher than the forces trying to stop it. So, firstly, we need to apply a pressure that is going to be sufficient to overcome the airway and tissue resistance of the system. And this is essentially got to do with the flow of gas down the tube and into the lungs. So resistance is influenced by flow, is a marker of flow. And if you think about it, what sort of things affect resistance? Resistance has got to do with the tube. So it's the airways. Yeah? And we know this from the different lung diseases we manage. If we're managing a baby with HMD, we have a lung which has very little resistance. There's nothing stopping gas getting from my ventilator to an alveolus. Yeah? But if I'm managing a baby with bronchiolitis or a bad MAS baby, there may be many things in that tube, the airway and the major airways, which are stopping gas getting there. So therefore, the time it's going to take for gas to get there to the lung to allow an alveolar change will be higher. So in that lung, resistance is a problem. So resistance is the first thing we need to consider. We need to apply enough pressure to overcome inertia, which has really got to do with the way gas accelerates into our lung. And essentially, this is a good one because in a neonate, this is insignificant, and there's no lung conditions where inertia is a big problem. So we can ignore this, it's essentially zero. And finally, if we can get the pressure to get down the tube and get into an alveolus, we need to make sure that pressure is sufficient to get the lung to move, so that we get a volume change within an alveolus. And that has got to do with the things that stop the alveolus moving, and that is essentially elastic recoil and elastance, isn't it? The inability of the spring to move out. And the inverse of elastance, as we all know, is compliance. So compliance is how easy something will move. Is it compliant or not? If I push it, will it fall over? Or will it push back? So putting this all together, to initiate a volume change in an alveolus, we need a delta P that firstly is sufficient to overcome the recoil of the lung and overcome any resistance, which is a measure of flow in the system. And also we need to consider the effect of surfactant and surface tension on the alveolus and how easy it is to move. And as we all know, if you have a system without surfactant, it is less compliant than a system with surfactant. And this just summarises this again and brings in the concept that these forces that the lung have occur in inspiration and expiration. We think a lot about inspiration, but expiration is very important. So in inspiration, we have an active process on a ventilator. Gas needs to get in, move it. Then in expiration, it's passive. Now we need these forces that we've overcome to allow the lung to deflate. So we need to have an elastic recoil to push gas out as we take the inflating pressure away, and we need to have enough time to allow that gas to flow out of the lung. And here again, resistance becomes important in some lung diseases. So time is now something we need to think about as well. We need to have enough pressure to move the lung, and that is dictated not by the ventilator but by the baby. And we need to allow enough time for the movement to occur in inflation and expiration. The change in volume that will occur in the lung is a product of the delta P we apply and the compliance of the system. Okay? It takes time though for that volume to change. It doesn't suddenly go like this, does it? We don't go, we breathe in a much slower way and we get a nice exponential change in volume. So we need to make sure we get to apply enough time here to get this volume change. And the time constant of the lung is a way of describing how much time we need for the lung to inflate and deflate. And these concepts cover all modes of ventilation. And that is essentially compliance times resistance. So again, we're coming back to these two forces we're considering in the lung when we ventilate. And when we apply a change in pressure, a delta P for example, or on an oscillator, a change in mean airway pressure, or a change in peak or convention, there will be a volume change. It will either go up or it will go down. Okay? And it will change in this way inside an alveolus. It doesn't change linearly, it changes in an exponential pattern. And this has been well known for a long time, and again, this is another essential formula that I'd expect that you all know by the end of the week. Fundamentally for us at the bedside, what it means is that this exponential relationship can be used in our head to get the right eye times. Okay? So time constant talks about the time it takes one time constant is the time it takes for 63% of a volume change to occur when you apply a change in pressure. Okay? So obviously if we apply a delta P, we want to get to the tidal volume in the lung. And the time we need to do that will be at least 3 time constants. 3 time constants gets us to 95% of the maximum volume change we can get in the lung. 5 time constants is 99%. So ideally we need to make sure we apply our delta P for at least 3 time constants and ideally 5 time constants in the system. Okay? And that's really important because if we're doing a mode like volume guarantee and we don't give enough time for the lung to inflate, we won't get to the tidal volume we want. What will the ventilator do? It'll go, I was told to give 5 ml per kilo. I'm not giving 5 ml per kilo, therefore I have to do something about it. And the ventilator and that engineer has told me that if I don't get what I want, I should up the delta P. So the ventilator will put the delta P up. And that's not because the baby needed more pressure, that's just because you weren't allowing enough time for the pressure to go in. So getting the right time is fundamental, and I'll give you some examples of that. Oh, this isn't translated well. Anyway, so in the normal lung, do we have a problem with compliance? No, compliance is normal. Yeah. And do we have a problem with resistance? No, gas can go in and out of the lung pretty easily, right? So in the normal term in neonate, 1 time constant is about 0.1 of a second. Yeah? So that means we will need an I time of about 0.5 of a second to inflate that lung adequately. Yeah? Does that make sense? What happens if you have active parenchymal lung disease like HMD? Is there a problem with gas getting in and out of the lung? Sorry?
Yes.
Really? Getting into the alveolus? No. With atelectasis, with HMD, the airways are generally pretty good, right? Unless there's still liquid filled for birth or something, but there's no problem fundamentally with the airways. Gas can move very quickly in and out. So there's not a resistance issue. Resistance is normal. But the difficulty is in how that lung moves, right? There's a problem with compliance. Compliance is much lower, yeah? And we'll talk maybe in the lab and in the workshops about what normal compliance settings are and abnormal compliance settings. So compliance is low. Gas will get there quickly, and if you give enough pressure, you actually move it very quickly, the alveolus. So consequently, our I time, compliance time to resistance, is very short. So we don't need much time to move that one. So an I time here of as little as 0.1 to 0.2 second may be adequate to move an alveolus with HMD. And consequently, you can see we now have a much shorter I time than we would on in a term baby being ventilated for whatever reason. And this is the rationale behind the short I times that are being used. That's why everyone tells me around the world they put all their preterm babies on I times of 0.3. There is a logic for that, but we'll talk a bit why that's sort of in some way counter-logical because we should individualise it. But if you then take a baby with bronchiolitis, do they have a problem with airway resistance? They do. So it's going to take a long time for gas to move into the lung, just to get to an alveolar. And then when it gets into the lung, there may or may not be a compliance problem. There generally is in bronchiolitis because you get a bit of parenchymal disease as well. But if there isn't a significant compliance problem, you can suddenly see that the time you need to move the lung is much longer than a term baby. So if you put that baby on an I time of 0.3, you're only getting to about 70% of total lung volume change with each inflation. And that's what I've just summarised there. I'll just move on. We don't sit on the ward round with a calculator and look at the compliance and resistance measures, even though the ventilator companies put them on the ventilators now and then calculate time constants. What we do is we look at what's available to us from the monitoring. And the modern ventilator, and many of the modern oscillators provide a lot of information and feedback to the clinician who wants to look at them. And the key thing is to look at the way gas moves in and out of the lung, and that's got to do with flow. So, as we know, flow of gas is positive in inspiration and negative in expiration. And we can see from the flow wave that it goes in very quickly, and then it starts to plateau out as you get to the point of end inspiration. And at end inspiration, you'd expect there to be zero flow in the lung. And we can see this in our own lungs by just concentrating on our breathing patterns. So if you think about what happens when you breathe in, you can feel gas enter your chest. And then at the end of your breath in, there is no gas entering the chest. You reach a steady state. And then you breathe out again, gas leaves your chest, and you reach another 0 point or steady state. So we expect for the ventilator to be set properly, that at the end of inflation and at the end of expiration, there is zero flow moving in our circuit. So what we want to see is a waveform that has been applied for sufficient time that we get 2 points of zero flow. And this is how we can set our I time and our E time. I'll talk about this on the oscillator because you can't do this on the oscillator. You have to use the principles, but you can't look at the flow waves per se because of the speed they're moving and the way and the fact that in high frequency you don't actually get zero flow points at the end of inflation and expiration on a modern oscillator. So if this was a flow wave, what could we do here? Yeah, here you've got an I time that's insufficient, haven't you? Because expiration is starting here before you get back to zero flow. So for this baby, irrespective of what you think the I time should have been, because you always use 0.3 or 0.4 or whatever, this baby wants a different number, okay? And you have to increase your flow to get back to allow increase your I time to allow the lung to have enough time to finish inspiration. So this is flow interruption. How long should you have your I time set for? Approximately less than a third of total inspiratory time. If you have it too short, so it just hits zero flow and starts again, you may not be allowing all the alveolus to finish inflation because this is just a measure of the flow of the airway opening and we're inferring about how it's behaving in the lung because at least in conventional we're not assuming there's an attenuation of our waveform. Okay? But this doesn't tell you that the distal alveoli will take longer to inflate because gas has to get there compared to the ones that are sitting right up here near the major airways. If you have flow too long, it's firstly really, really inefficient because it's a waste of time. Secondly, you're holding a lung open that doesn't need to be there, that actually wants to expire. So there could be an increased risk. So you want just a little bit of time on zero flow. What do you do if you have a leak? Oh, all my graphics has gone crazy on George's bigger Mac. So if you have a leak, you will never get back to zero flow in your waveform at the end of inflation because some of the gas that the flow sensor has seen go in can't come back out past the flow sensor that has disappeared into the environment. So you'll get this plateau occurring, okay, where the flow wave doesn't go back to zero and then expiration starts, okay? This doesn't mean you can't set your I time when you've got a leak state. What you need to do is just to offset your own brain and go, all right, well, I know there's a leak, so I just want to see my point of zero flow is essentially here now. So in this case, I've got too long an I time. I could set my I time to finish here. And this is relevant, of course, when we think about flow termination on ventilators, because we sometimes use modes that are flow cycled. And when a ventilator talks about flow termination, we're talking about how the ventilator knows when an expiration should start. And this has impact on the sort of pressure and volumes you could be achieving. If you have your flow termination set too high, you can see here you're truncating the baby's ability to finish its expiration, and we'll get a lower tidal volume as a result. So I think I'll quickly talk about this. I might go over this because I think Anton might. Are you going to talk about PSV and termination sensitivity? Yeah. I realise I'm encroaching into your sort of area now. So, but I want to talk. This is mainly on conventional, but the principles we'll see in the talk on high frequency apply here as well. The flow of gas has to go in and out of the lung. We need to understand about how gas moves so we can apply high frequency as well as conventional problems. So the flow you set on the ventilator is also important. So most of us have no idea what flow of gas a ventilator is giving to the lung because we assume it must be right because the ventilator company told us it this, and most of the time it's not even displayed, and that's not a bad thing, right? But here's an example of what would happen if you have different flow settings. So if you apply a very high flow of gas to the lung, you will get a very, very quick change in volume occurring, and because you get a very, very quick change in pressure occurring in the lungs, and that makes sense. Because the quicker the gas goes, the quicker the pressure change will happen. So this will give you a very square wave on your pressure waveform. Okay, and you can see here, you get a very short time for your I time, because gas moves quickly. Now, if you apply a much lower flow to the lung, you will get a more rounded pressure wave. And you can see as long as you set your I time appropriately, you account for the lower flow, you can still get the same volume occurring in the lung, right? It just occurs later. Now, this is potentially an important way we can use the ventilator in certain circumstances. Firstly, flow may have its own effect on injury. You can imagine if gas is going very, very quickly into the lungs, giving you a square wave on your pressure, what's happening? It's going like this, right? Really pushing hard. And that is going to create lots of forces on the lung, which could increase the shearing pressures that are occurring across both the airway and the alveoli. So if you have a very, very fragile lung, too fast a flow may in fact increase your risk of lung injury. And this is the concept of rheotrauma. Okay. In those sort of environments, slowing the flow of gas down will more gently change pressure and more gently change volume, and that may in itself be a more protective approach. And we were talking about this in Calgary. Many of us now, and I do this, if I've got a very early prem baby, I have the ability to use slower flows because I've got usually a lung that is mechanically needing very, very short I times. So I get a lot of breaths in if I want it. So if I slow the flow down, I can usually still achieve minute ventilation because I can have a bit longer in inspiration but still have enough breath to move my CO2 in and out, and potentially that is going to be a more protective approach. Also, if I've got the baby triggering, is a way of slowing the baby down if they're auto-triggering on a ventilator. And that's particularly important when you think about the fact that after we inflate the lung, we also need to allow the lung to deflate. So we need to see that the flow wave has enough time, or the lung has enough time to get back to zero flow before inspiration starts. And here you can see if you have your rate too high, we've got breaking of flow and inspiration occurring before the next breath, before the lungs deflated, sorry. So what will that mean? Air trapping, yeah. And it will give you auto peak, won't it? So we'll get air trapping, we'll get auto peak, we'll get a lung that's doing this, not a lung that's doing this, which is what. And we have to remember that in expiration, because it's passive on most ventilators, resistance is a more important mechanical concept to bear in mind because you have less control of it and it takes longer to deflate a lung than it does to inflate a lung. So if you've got resistance in your lung disease, expiration is often the key to getting right. What's happening here? Anything? It's all looking pretty good, really, isn't it? Yeah? What's going on in this lung? Have we got... Sorry? Yeah, there's quite a bit of resistance, isn't there? Yeah. We're in air, but we're needing massive pressures, right? Yeah. Yeah. So here we're not allowing the lung to properly deflate, I think, and we're getting a bit of auto peak. Yeah. We'll talk about this in the workshops about how to set the ventilator settings. So compliance is the ability for the system to move when a pressure is applied to it. Okay? And as you all know, compliance is delta V over delta P, and during tidal ventilation, that's tidal volume over delta P. And that occurs when you're on a jet, an oscillator, or a conventional ventilator. And The inflation curve, which goes from functional residual capacity or P all the way up to the end of inspiration, delta P, or in some cases total lung capacity, is not a linear relationship. It's a sigmoidal relationship, and there's a reason for that, which I'll show you at the end. Essentially, compliance is what influences our tidal volume. So to get tidal ventilation, we need to have enough pressure, and we need to apply that pressure in the circuit that's appropriate for the compliance of the system. So in this case, as the lung becomes more compliant, we can see that the tidal volume we achieve for any given delta P will increase. And of course, there's one environment where we do this very quickly, and that's when we give surfactant. We can use PV curves or PV loops to try to understand compliance. Personally, I don't use PV loops when I'm ventilating babies that often. I don't think they change my practice. I just use the flow waves and the pressure wave. But some people swear by them. And obviously you would expect, if you have a poorly compliant lung, a lot of pressure causes a little change in volume, you'll get a loop like this. And if you have a very compliant lung, a small amount of pressure causes a large change in volume, and you get this sort of loop. And then if need be, if you're interested, you can also look at the upper part. This is what the C20 does. It looks at whether you're getting the upper part of the curve to see whether that's inadvertently high or low, and uses a marker of overextension. The loop is not linear. So the pressure-volume relationship, the relationship between pressure and subsequent lung volume is not linear. The way the lung inflates is different from the way the lung deflates. And do you know what this concept's called? Hysteresis. Excellent. So hysteresis tells us that tells us about the mechanical properties of the system. This is a springy system, okay? And it remembers what's happened to it. A recruited lung will behave differently from an unrecruited lung. And we'll talk about this in high frequency because this is critical to understanding lung recruitment. And I think Anton and I will probably harp on about this quite a bit. Fundamentally for us at the bedside, what it means is for any given pressure we want to apply to the lung, there is a range of volumes we can achieve. And therefore, for any given volume we want to have in the lung, there is a range of pressures that could achieve that. So it's incumbent upon us to find the pressure that's best for the volume that we think that lung needs. And it isn't a linear relationship because the way the alveolar volume changes isn't linear, it's exponential. Unfortunately, we live in an environment where there's gravity. So especially if you have a disease lung and you're lying on your back here, and this is from an adult ARDS type lung injury, you have gravitational pressure being opposed, and what that means is that the alveoli that are right up here, the non-dependent alveoli, have less forces squishing them than the ones down here. The alveoli down here have to do a lot more work to open up than the ones up here. They've got it easy. The ventilator pressures can be variable, and the opening and closing pressures, the pressures where we suddenly start to get recruitment in the alveolus and the pressure where recruitment stops, are not even throughout the lung. They're normally distributed. So some alveoli will open at a low pressure and some will need a very high pressure to open. Conversely, they will close at different pressures. Practically, this means that lung volume affects perfusion and diffusion, and we all know this. So an unrecruited lung will have worse perfusion. Then as it engages in recruitment, we can see we get more surface area for gas exchange, and our capillaries will not be as inefficient, and then when we over-distend the lung, we're getting compression of capillaries. And this means that, and also there's a relationship between oxygenation here that's similar to the volume. So we'll talk about the ability to use oxygenation later to guide lung volume, given we don't have direct measures at the bedside. So in summary, this is just a brief talk to talk about these concepts of time constants, compliance and resistance, because without those three things, we can't set pressure, and we can't set rate, and we can't know how to get the most efficient ventilation, whatever mode we use. And it's the interaction of these relationships with time and tidal volume that are important. And it's from pressure and flow, at least on a conventional ventilator, that we can unlock these mechanical properties. And on an oscillator, we have to be a little bit clever in what we do. So That was the end of that talk. Are there any questions?